All right, so a very good evening, everyone. Yes, so quickly tell me, am I audible and visible to all of you? Just give me a quick thumbs up in the chat box and please tell me, am I audible and visible to all of you? Okay, so now let us discuss some of the previous year questions of the NEET PG, so which will be definitely useful for the upcoming NEET PG exam. So we'll try to take this little lengthy session where we'll try to discuss as many possible previous year questions of general medicine, which will be definitely useful for your upcoming NEET PG exam, which is on March 5th. So having said this, let us start the discussion with a clinical scenario. A 42-year-old man with long-standing type 1 diabetes mellitus presents with the gastroenteritis, right? Presents with gastroenteritis that has been worsening for 5 days. His serum biochemistry values are consistent with diabetic ketoacidosis. His blood pressure is 90 by 55 millimeters of mercury. His heart rate is 135 beats per minute. Other laboratory findings are as follows. The blood glucose levels are 656, sodium 127, potassium 4.2 milliequivalents per liter. Bicarbonate, it is 14 milliequivalents per liter. Anion gap of 25 and pH of 7.05. Which of the following would be an appropriate step in the immediate treatment of this patient? Now, the options if you see in this question: IV administration of saline, admit to the intensive care unit, supplementation of potassium chloride, IV administration of insulin, IV administration of sodium bicarbonate. Right? Yes, any one of you? So, if you see the correct answer in this question, it is a case of the diabetic ketoacidosis. And in a case of diabetic ketoacidosis, what is the first line treatment? Right, very good, Priya Thakur. The correct answer is the IV administration of the saline. That is normal saline. That is the first line treatment in patients with the diabetic ketoacidosis. It is not the administration of insulin or it is not the administration of the potassium chloride. So, sorry, I'm very sorry. Okay. The question asked is, which of the following would not be? I'm very sorry for this. I'm very sorry. So the question is, which of the following would not be the appropriate step in the immediate treatment of this patient? So the correct answer here is the IV administration of the sodium bicarbonate. That is not an immediate treatment step for this patient of diabetic ketoacidosis. Now let me explain you the management of diabetic ketoacidosis quickly. So what do you think is the first line treatment? The first line treatment in patients with diabetic ketoacidosis will be the administration of the IV fluids. Now, after the administration of the IV fluids, the next important is you need to give the insulin, right? And how will you give insulin? Like you need to give 10 units bolus, right? You need to give 10 units bolus. Followed by that, you need to give 0.1 units per kg body weight. IV infusion is what you need to start. Right, IV infusion is what you need to start. Okay, so that will be the second line, that is administration of the insulin. Now, this diabetic ketoacidosis is a medical emergency where the individual will have severe dyspnea. Definitely you need to admit the patient to the ICU. Now, coming to the potassium chloride supplementation. How much is the potassium chloride in this individual? 4.2 milliequivalents per liter. Even though it is normal, you need to supplement the potassium chloride. Now, what is the indication of supplementing the potassium chloride in a patient with diabetic ketoacidosis? When the potassium level, if it is less than 5 milliequivalents per liter, that is the indication to start the potassium chloride infusion. That's an indication to start potassium chloride infusion. Now, sir, when the potassium is normal, why is that you need to give potassium chloride infusion? The reason is that whenever you are giving insulin infusion, this insulin infusion will reduce the serum potassium levels, right? It will shift the extracellular potassium to the intracellular compartment. That is the reason why you need to give KCl when the potassium chloride levels are less than 5 milliequivalents per liter. Now, what are the other treatment options? Now, very important precipitating factor for diabetic ketoacidosis is the infection. So you need to give antibiotics. And the next important thing is you need to give antibiotics. And next important is, what is the indication to start the sodium bicarbonate infusion in this patient? See, in this patient, sodium bicarbonate is not required. But what is the indication to start the sodium bicarbonate is, you need to start the IV sodium bicarbonate when the pH of the individual is less than 7, and when the bicarbonate value, if it is less than 10 milliequivalents per liter, that is the indication to start the sodium bicarbonate. Now, what is the pH of our patient? It is 7.05 and bicarbonate is 14 milliequivalents per liter. So it is not the indication where you need to start the sodium bicarbonate. So which is not required as an immediate step in the management of this patient? Administration of sodium bicarbonate is not required in this patient. So the correct answer is, the answer here is E. Okay, right. Okay, so now we'll move on to the next. Okay, this is one of the image based question. Okay, so the question is, for calculation of rate related QT interval, QT is divided by, right? QT is divided by root of X, right? So this is the formula. QT is divided by root of X. Now, what exactly is this X? What exactly is this X? Very good. So this particular X is, that is 4. Now, what should be your QT divided by root of RR interval? That is what is called as the corrected QT, right? Which we call it as the QTC. Okay, that is nothing but your corrected QT. Now, what is your RR interval? This is your RR interval, which is being represented by 4, right? Which is being represented by 4. So that is the reason why the correct answer is 4. B option. Now, what is the normal QT interval? The normal QT interval, it is around 360 to 440 milliseconds. That is the normal QT interval. Okay, right. Now we'll move on to the next important PYQ. See, these are all previous year questions. I'm not trying to frame any new clinical scenarios. Whatever has been asked previously, I'm trying to just show you. Now, the marked part of the ECG called as X points to which phase of the cardiac action potential. So which part is, okay, this is the X. Now what X represents? X represents the ST segment. Right? Now tell me, your X on the ECG points to which part of the action potential? Right, so the correct answer here is phase 2, right, which is nothing but the plateau phase. So plateau phase is what corresponds to the ST segment on the ECG, whereas you take phase 0. Phase 0, it corresponds to QRS complex, that is your depolarization. Phase 1, it represents the onset of the ST segment, and your phase 2 will be your ST segment, and your phase 3 will be T wave, right? Your phase 3 will be your T wave. Okay, so that is what is the correlation between the ECG and as well as the cardiac action potential, which has been asked previously. Okay, next. Yeah, which is the location of Erb's point during the auscultation? Which is the location of the Erb's point during auscultation? So go through all the options. Second intercostal space, right parasternal line. Second intercostal space, left parasternal line. Third intercostal space, left. Fifth intercostal space, left. Right. So the answer is C. That is third intercostal space, left parasternal line. Okay, this one. And it is the Erb's point where you will listen the second heart sound. So which is that particular auscultatory area where the second heart sound is heard best? The second heart sound is heard best in the Erb's point. Okay. Now, what are the other areas? Like this will be the aortic area, which is in the second right intercostal space adjacent to the sternum. But one quick question for you is, which is considered as the Gibson's area? Yes, which of the area is considered as the Gibson's area? Any one of you? Which of the area is considered as the Gibson's area? So Gibson's area, if you see, it is the one which is used for listening the Gibson's murmur. And Gibson's murmur, you hear that in patients with the patent ductus arteriosus. Now, what exactly is your Gibson's area? Your Gibson's area, it is the first left intercostal space adjacent to the sternum. Right, first left intercostal space adjacent to the sternum. That is what is the Gibson's area. Okay. Right, that is mainly useful for listening the Gibson's murmur, which is heard in the patent ductus arteriosus. Okay, and that was one of the PYQ, previous year question. Now the next question is, a female has systolic blood pressure of 130, diastolic blood pressure of 100 millimeters of mercury on 2 consecutive occasions. Now what is the best treatment for this patient? Rest, sedative, antihypertensive drugs, error in the blood pressure machine. Yes, anyone? So now this patient is having diastolic hypertension, and this diastolic hypertension, whichever is there, it is present on the 2 consecutive occasions. So it is not the rest. You have to start the antihypertensive drugs because there is isolated diastolic hypertension which is being present on 2 occasions. Now, what are the etiologies that will cause the diastolic hypertension? Number 1, it will be essential hypertension. Right? Number 2, hypothyroidism. Right? Number 3, Conn syndrome. So these are the 3 conditions where you will have the diastolic hypertension: essential hypertension, hypothyroidism, and as well as the Conn syndrome. Okay, right. Now, because the patient is having diastolic hypertension on 2 occasions, definitely you need to start with the antihypertensive drug without any doubt. Next question you see. All are true about renal artery stenosis except, which is the incorrect statement. The options are ACE inhibitors can be used in bilateral renal artery stenosis, can be used in unilateral renal artery stenosis. ACE inhibitors are the best drug to control diabetes mellitus associated hypertension. And excision and grafting is a treatment of choice. Angioplasty with or without stenting and surgical bypass used only in refractory cases. Right. So which is the incorrect statement? The question asked is except. So remember, when there is bilateral renal artery stenosis, the ACE inhibitors, they are absolutely contraindicated. Whereas in unilateral renal artery stenosis, we can give ACE inhibitors. In diabetes with hypertension, the best drugs are the ACE inhibitors. Excision and grafting is definitely the treatment of choice. And what is the type of angioplasty that we will do is percutaneous transluminal renal angioplasty, that is PTRA, is the angioplasty that you need to do in refractory cases. Okay, right. So the one which is incorrect statement is A. And what are the other absolute contraindications for ACE inhibitors? One is your bilateral renal artery stenosis. Now, is there any other? Yeah, one second. Even your D is also incorrect. I'm very sorry for that. So even D, excision and grafting is a treatment of choice. This is also an incorrect statement. So that means you have two answers here, A and as well as D. A and as well as D. Okay. Right. So the other absolute contraindications are in pregnancy. Pregnancy is also another absolute contraindication for the renal artery stenosis. Sorry, for your ACE inhibitors. Okay, right. So ACE inhibitors should not be given even in pregnancy. Now we'll move on to one more image-based question, but it was an easy one which was asked previously. A 35-year-old lady has been diagnosed as having anxiety neurosis by her psychiatrist. She came to you for second opinion. Comment on the diagnosis based on the ECG. The options are sinus tachycardia, WPW syndrome, multifocal atrial tachycardia, atrial fibrillation. So, what exactly you think? No, it is not atrial fibrillation. It is not atrial fibrillation. It is a very simple sinus tachycardia. It is a very simple sinus tachycardia. So you can observe here the history, that is the patient is having the anxiety neurosis. That itself tells you that the individual might be having the tachycardia. So whatever the picture which has been given to you here, the rhythm of the ECG is regular. When rhythm of the ECG is regular, we don't consider it as the atrial fibrillation, because in atrial fibrillation you should have irregular rhythm. Then all the P waves, if you observe all the P waves, they are of similar morphology. In case of multifocal atrial tachycardia, what you should have, more than or equal to 3 different P waves should be there. More than or equal to 3 different P waves should be there, which is not there. So your multifocal atrial tachycardia is also ruled out. Now in WPW syndrome, what is that you should have? You should have short PR interval, delta wave and wide QRS complex. So all these you are not having. PR interval is normal, there is no delta wave, there is no wide QRS complex. So that is the reason why your WPW syndrome, that is Wolff-Parkinson's-White syndrome, is also ruled out. Okay, right. So that is about the sinus tachycardia. Now you see the next question. Osler's maneuver is used for the diagnosis of pseudohypertension, infective endocarditis, auscultation of murmur of mild AR, cutis laxa. What is the correct answer? No. I'm not talking about Osler's nodes. I'm asking about Osler's maneuver. Very good, Venkatesh. So, Osler's maneuver is used for the diagnosis of the pseudohypertension. Now, where do you come across this pseudohypertension is? You come across this pseudohypertension in the geriatric patients. And why do you have that pseudohypertension in geriatric patients? That is due to severely sclerotic arteries. Right, that is due to severely sclerotic arteries. You have the pseudohypertension in geriatric patients. Now this leads to overdiagnosis of hypertension in these patients, and that is the reason why it is called pseudohypertension. Now in such case we use a maneuver called the Osler's maneuver. Now what exactly we do in the Osler's maneuver? Osler's maneuver is characterized by, right, it is characterized by palpable radial artery, right, in spite of, right, palpable radial artery in spite of occlusion of brachial artery by BP cuff. Okay, with the help of the BP cuff you have occluded the brachial artery. When you have occluded the brachial artery, what is that should happen? Even you should not be able to feel the radial artery pulsations also, you should not feel the radial artery also. But in spite of the occlusion of the brachial artery by BP cuff, still your radial artery is being felt. That is what is called as the Osler's maneuver, which is suggestive of the pseudohypertension. Okay, right, which is seen in geriatric patients due to sclerotic arteries. Yes. Which of the following leads to hypokalemic metabolic alkalosis with hypertension? Hypokalemic metabolic alkalosis with hypertension. Right. So the correct answer here is the Liddle syndrome. Right. So in case of Liddle syndrome, what exactly is the problem in Liddle's? It is a genetic disorder where you have autosomal dominant type of inheritance, and that is due to increase in the activity of the epithelial sodium channels. And in these patients, there will be increased sodium and water retention, potassium excretion will be there, and as well as H+ion excretion will be there, and that is the reason why this will cause the hypertension with hypokalemia and as well as the metabolic alkalosis, right, as well as the metabolic alkalosis. That is what you will observe in case of the Liddle syndrome. Now, whereas you take in Barter's and Gitelman's, in Barter's and Gitelman's, these patients, they will have the hypokalemia and they also have metabolic alkalosis. But the point is, this Barter's and Gitelman's, the blood pressure will be normal in these patients. They will not have hypertension. So that is the reason why Barter's and Gitelman's are ruled out. Now, what about in renal tubular acidosis? That can be easily ruled out because these patients, they will have metabolic acidosis but not metabolic alkalosis. So in that way, your renal tubular acidosis is also being ruled out. And one more important point you need to know about the Barter's and Gitelman's. Barter's, it resembles what? It will resemble the loop diuretics. And Gitelman's, it resembles the thiazide diuretics. Okay, so that is what you need to remember. Next question. Mitral valve vegetations do not usually embolize to lung, spleen, liver, brain. Mitral valve vegetations do not usually embolize to. Very good. So mitral valve vegetations usually they don't embolize to the lung. See, from the mitral valve, if there is any vegetation, if it is being ruptured, it moves in the forward direction. That means it will move into left ventricle and aorta, from aorta to the different systemic organs. But backward flow or backward embolization to the lungs does not occur if there is the mitral valve vegetations. Okay, right. Next question. Now, please comment on the ECG findings of the patient. Atrial fibrillation, atrial premature contracture, paroxysmal supraventricular tachycardia, WPW syndrome. What exactly would be the diagnosis in this patient? No. This is not. This is not the WPW syndrome. This is not the WPW syndrome. So it is the ECG of a simple atrial premature contracture. It is the ECG of a simple atrial premature contracture. Now you take all the options. In atrial fibrillation, what is the point? There should not be P wave and rhythm should be irregularly irregular. Definitely rhythm is irregularly irregular, but you have the presence of the P waves. See, this is a P wave, this is a P wave, this is a P wave, and this is a P wave. But in between the complexes, right, in between the complexes, you have an intermittent atrial ectopic. So how is that you can tell it is an atrial ectopic? Because the P wave is abnormal. So that tells you it's an atrial ectopic, which is nothing but atrial premature contracture. Now, why is it not PSVT? In PSVT, the rhythm will be the regular rhythm. But in this ECG, the rhythm is irregular. So your PSVT is ruled out. In WPW syndrome, you should have short PR interval. Then you should have the delta wave and you should have the wide QRS complex, which is not there in the ECG. So that is the reason why your Wolff-Parkinson's-White syndrome is being ruled out. Okay. Now you see the next question. Which of the following is not true about the infective endocarditis? Hematuria, rose spots, splinter hemorrhages are seen, the hemiplegia. Which of the following is not seen in the infective endocarditis? So, right. So this is a very simple and easy question. And if you overlook the options, I did not get the correct answer from any one of you until now. No, no, no. If you overlook the options, you are gone. You have to read the options properly. No, no, I did not get. Yes, Sana Menon and as well as Dr. Refarmer. Now everyone is answering. Okay. So please remember, it is in infective endocarditis what you see is Roth spots, not the rose spots. Whereas hemiplegia, does it occur in infective endocarditis? Yes, it occurs in infective endocarditis. Why it will occur in infective endocarditis? That is because of the embolization. Right, that is because of embolization. Now, where do you come across this rose spots? Any one of you? What are the conditions where you come across this rose spots? This rose spots, you come across this in 1/3 cases of typhoid fever. Right, in 1/3 cases of the typhoid fever who have not been treated, you come across this rose spots. And not only that, you can see these rose spots in other conditions like Shigella. So even in case of the shigellosis, you can have this rose spots. So these two are the differential diagnosis for the appearance of the rose spots. And these rose spots, like when do they appear in typhoid fever? They appear as a rash. They appear between 7th and the 12th day from the onset of the symptoms. Right? They appear between 7th and 12th day from the onset of symptoms. And whenever they appear in groups. Right? They appear in groups of how many lesions? Of nearly around 5 to 10 lesions that will be there. Either they are seen over the upper back or over the lower chest or the upper abdomen. Okay, and these rose spots, whenever they appear, they last for 3 to 4 days. Right, they last for 3 to 4 days. That is what is your rose spots. Okay, and hemiplegia will be there because of embolization. Hematuria can also be there. That is because of the glomerulonephritis, and splinter hemorrhages are also being seen in patients with the infective endocarditis. Okay. Yes, JJ, you have, I think if I am not wrong, you have asked this previously also. Not to worry, you can comfortably do general medicine even though if you have mild tremors. Okay, very simple and easy question, and you should not miss this question. A 25-year-old woman presents with complaints of recurrent episodes of sudden onset palpitations. What does her ECG tracings show? Atrial flutter, atrial bigeminy, paroxysmal supraventricular tachycardia, sinus tachycardia. Right. So the question is your PSVT, paroxysmal supraventricular. Now this paroxysmal supraventricular tachycardia, this ECG you should not miss, because this PSVT ECG has been asked almost 3 to 4 times in the previous session. Either they will give you to diagnose the ECG, or they will give you like what will be the first line management, or they will ask you what will be the drug of choice in these particular patients. Right, or they will ask you like what is the alternative drug apart from adenosine. Apart from adenosine, what is the other alternative drug? That is your verapamil and as well as diltiazem if it is calcium channel blocker, or the other important drugs will be your beta blockers. These are the drugs that you can give. Okay, now we'll move on to the next question. Right, infective endocarditis is least common in. Infective endocarditis is least common in So very good. Reformer and as well as Rajput has answered, and all those students whoever is answering ASD. So in case of atrial septal defect, the chance of development of infective endocarditis is less, whereas your mitral stenosis, the chance of development of infective endocarditis is moderate, whereas in aortic stenosis and ventricular septal defect, the chance of development of aortic stenosis is high. Okay, what is that you have to remember is the concept, that is those lesions which has high pressure change, they are the one at high risk of development of infective endocarditis. You take aortic stenosis and ventricular septal defect, these are the lesions which are present across the higher pressure gradient. So those lesions which are having a higher pressure gradient, they are having the increased risk of infective endocarditis, and those lesions which are having low pressure gradient, they have low risk of development of infective endocarditis. So ASD has the low pressure gradient, so that is the reason why it is at lesser risk of development of infective endocarditis. Okay, right. Next, you see the another question. A hypertension patient is having severe chest pain, after which he developed unilateral ptosis and hemiparesis. The chest X-ray of the patient is shown below. What is the clinical diagnosis in this patient? Aortic dissection, acute myocardial infarction, cardiac rupture, atrial fibrillation with the embolic stroke. Right. So the correct answer in this patient is yes. So the answer is the aortic dissection. Now, what is the main point in diagnosis is the chest X-ray finding. What is that you are observing in the chest X-ray finding is that you are noticing that there is widening of the anterior mediastinum in patients of the chest pain at rest. Right? Widening of anterior mediastinum in patient of chest pain at rest. And that is very much suggestive of the aortic dissection. Now, what about the other options? If you take the, just 1 minute. Right. So if you see the cardiac rupture, so cardiac rupture you can easily rule out. Why? Because if there is cardiac rupture, the individual will develop the pulmonary edema. The individual will develop pulmonary edema if there is cardiac rupture. But how are the lung fields? The lung fields are clear, so that will rule out the cardiac rupture. And in patients with the acute myocardial infarction also, if at all, if the chest X-ray is required, why is it required for you? That is mainly to rule out the pulmonary edema. So the lung shadows are absolutely clear. Your acute myocardial infarction is also ruled out. Now, in atrial fibrillation, you don't have that widening of the mediastinum. So even that can be ruled out. But otherwise, if aortic dissection was not there, the closest choice in the question is atrial fibrillation. Why? Because the patient is having the hemiparesis, right? So the atrial fibrillation are the one which will be the source for your emboli, So the closest option next to your aortic dissection will be the D. Okay, right. So after moving on to the, yes. A cyanotic, very simple and easy question, but these are all PYQs, right? I'm not framing any of the new questions. A cyanotic baby has a chest X-ray as shown. Now, the probable diagnosis in this patient is no, you're not having box shaped heart. Yeah, what is that you are having is the boot shaped heart, which is classically suggestive of the tetralogy of Fallot. Now, what is that you are observing here? The individual or the patient is having the upturned apex of the heart. So what is the condition where you will have upturned apex? You will have that in case of whenever the patient is having right ventricular hypertrophy, you will have that upturned apex. Okay, now you take the other options. Box shaped heart. What is the condition where you can have the box shaped heart? Yes, any one of you? Very good. So that is seen in Epstein's anomaly, right? Epstein's anomaly. Okay, right. So that was about the boot-shaped heart. Now, infective endocarditis, where lifelong treatment is required. Infective endocarditis, where lifelong treatment is required. Aspergillus endocarditis, Liebman-Sachs endocarditis, Fusarium solani, Enterococci. Right. No, 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 not in Liebman-Sachs endocarditis. Liebman-Sachs endocarditis, you come across this in SLE. And what do these patients require? Valvuloplasty, that's all. Okay. Now, what is the clinical scenario of infective endocarditis where you require lifelong treatment is in case of the fungal endocarditis. Right, in case of fungal endocarditis, you need to give lifelong treatment. So among this, which is the fungal endocarditis, that is the Aspergillus endocarditis. And in this Aspergillus endocarditis, you need to give two treatments. One, you should do early diagnosis, and you should do rapid surgical resection. Okay, rapid surgical resection, and along with that you need to give the antifungal therapy. Along with that you need to give the antifungal treatment. This antifungal treatment, whatever you are giving, you should give it lifelong. And these patients with fungal endocarditis, as such, it is a very rare disease, but the prognosis is that the patient will have a bad prognosis. Right? And what is that lifelong therapy that you need to give is, so initially you need to give liposomal amphotericin B, followed by that you need to give flucytosine, right? Followed by that you need to give the flucytosine. Now okay, but what is the preferred agent? Right? What is the preferred agent? Actually, you are giving this flucytosine, but the preferred agent is the voriconazole. Right? The preferred agent is the voriconazole. That is in case of the Aspergillus. Whereas, if you take in case of the Candida endocarditis, right? In case of the Candida endocarditis, you need to give liposomal amphotericin B, right? Or you have to give, right? Or you have to give caspofungin. This liposomal amphotericin B or caspofungin, you have to give for nearly around 6 to 8 weeks. Right? You have to give 6 to 8 weeks. Then after that, you should give lifelong fluconazole. Okay, you should give lifelong fluconazole. Okay, so in case of Aspergillus endocarditis, you need to give voriconazole. This will be the drug of choice. Whereas in Candida endocarditis, for 6 to 8 weeks, you need to give liposomal amphotericin B or caspofungin. Followed by that, you need to give lifelong fluconazole. Okay. Yes. Yes, Priya Thakur. In Candida, you can give either of these. Liposomal amphotericin B or caspofungin should be given. Okay, right. Now, what is the most common cause of the infective endocarditis? Staph aureus, strep viridans, strep pyogenes, strep mutilans. Right. So the most common cause of the infective endocarditis is the Staphylococcus aureus. And you take the other options like the strep viridans, strep pyogenes, and strep mutilan. Now, you take this strep viridans. In which clinical scenario of or which type of endocarditis you have this strep viridans as one of the etiology for infective endocarditis? Yes, in case of late prosthetic valve endocarditis, you can have this strep viridans. And even in case of subacute infective endocarditis, you have, yes, even in case of subacute infective endocarditis, you have this strep viridans as the organism that will be causing. Okay, right. Now, yes, you see the next question. Osler's nodes are seen in, yeah, yes, Priya Thakur. In early, it is your Staphylococcus epidermidis, which is a coagulase negative staphylococci. So Osler's nodes, they are seen not spandana. It is not in rheumatic heart disease. It is not in rheumatic heart disease. It is in subacute endocarditis. Why is that you people answering B? Yes, Limo and Chand, and even Leo. Osler's nodes are seen in infective endocarditis, and these Osler's nodes, they are seen within the pulp of the fingers, and these Osler's nodes, remember, they are very tender. And now the next question is, these Osler's nodes, please tell me, are they the part of the immunological phenomenon or they part of vascular phenomenon? Any one of you? Yes? Are they immunological or they vascular phenomenon? No. They are not vascular phenomenon. They are not vascular phenomenon. Your Osler's nodes are the immunological phenomenon. Right? Osler's nodes are immunological phenomenon. So what are the immunological phenomenon in infective endocarditis? That is Osler's nodes and as well as the Roth spots. But which are your vascular phenomenon? That will be the Janeway lesions. Right? That will be the Janeway lesions. Okay? Right. So this is about your Osler's nodes. Okay? Next. Yeah. A similar question, I said you right. This ECG has been asked multiple times previously, but in different case scenarios. A 52-year-old male diabetic patient presents with palpitations to the AIMS emergency. Urgent ECG was performed. What is the immediate next step in this management? Yeah, even your glomerulonephritis, they are the immunological phenomenon. Actually, the immunological phenomenon in infective endocarditis are glomerulonephritis, Osler's nodes, Roth spots, and even rheumatoid factor. Even rheumatoid factor is also the immunological phenomenon in infective endocarditis. But what are the vascular phenomena in infective endocarditis? That includes the Janeway lesions, conjunctival hemorrhages, intracranial hemorrhage, mycotic aneurysm, septal pulmonary infarcts, and major arterial emboli. These are all vascular phenomena. There are totally 6 vascular phenomena. Okay, right. So this ECG, it is suggestive of paroxysmal supraventricular tachycardia. And in paroxysmal supraventricular tachycardia, what is the drug of choice? That is adenosine. This adenosine, you have to give IV bolus, and you have to give 6 milligrams IV bolus. And if 6 milligrams IV bolus, if there is no response, then you should give 12 milligrams IV bolus. And even with 12 milligrams IV bolus, if there is no response, then you need to give beta blockers or the calcium channel blockers should be given. And even then, if the patient is not responsive, then in such case, you need to do DC cardioversion, right? But usually the DC cardioversion is being advised whenever the individual is having hemodynamic instability. Hemodynamic instability. Okay, right. And your PSVT is what? It is a narrow complex tachycardia. It is a narrow complex tachycardia. Okay. Yeah, XYZ. If the patient is hemodynamically unstable with PSVT, definitely the first line treatment will be the DC cardioversion. Okay, now we'll move on to the next question. Which of the following is not a part of the Duke's criteria for infective endocarditis? Hmm? Which of the following is not the part of the Duke's criteria for the infective endocarditis? It is your splenomegaly. Splenomegaly, it is not the part of the Duke's criteria. Whereas fever more than 100.4 degrees Celsius, that is minor criteria. The blood culture being positive, it is present in both major and as well as the minor criteria. But what about the IV drug abuser? Yes, what about the IV drug abuser? IV drug abuser, now tell me, is that point, is it part of any criteria? Okay, fine. Fever more than 100.5 degrees Fahrenheit. Okay, it's okay. Yes, it is a part of the minor criteria. Very good, Limo. So in the minor criteria, we learn one thing, but we miss one thing. What is that we learn? Presence of predisposing cardiac condition. Presence of predisposing cardiac condition. But what is that we miss? We miss presence of predisposing heart condition or IV drug abuse. This point we will miss. But remember, even your IV drug abuse is also one of the minor criteria in the Dukes. That is also one of the minor criteria in the Dukes. Okay, so you should not miss this IV drug abuser. But splenomegaly is not the part of your Dukes criteria at all. Okay, then yes. Yeah, you answer this. A 15-year-old child of valvular heart disease on the heart failure treatment has the following ECG tracing. What is the diagnosis in this scenario? Okay, basically the question is like, what is the diagnosis of the ECG which has been given to you? Right, so this is the ECG which is very much suggestive of, very much suggestive of the ventricular bigeminy. So you can see very clearly here, this is the normal complex, this is the ventricular premature complex, this is the normal complex, this is the ventricular premature complex. So this is classically suggestive of the ventricular bigeminy. Now in case of ventricular, okay, now tell me what is the drug this patient is taking for the development of the ventricular bigeminy? What is the drug this patient is taking for the development of the ventricular bigeminy? Very good. So this patient is taking digoxin. So what the patient has developed is, the patient has developed digoxin toxicity. Right? The patient has developed digoxin toxicity. So that is what is the one which causes the ventricular bigeminy. All right. Next. Now we'll move on to the next. Yeah, the presence of the giant A wave occurs in all of the following conditions except junctional rhythm, pulmonary hypertension, tricuspid regurgitation, complete heart block. Giant A wave in JVP occurs in all of the following conditions except, very good, that is in tricuspid regurgitation. So in tricuspid regurgitation, what is the abnormality that you will have within the JVP? In tricuspid regurgitation, the abnormality that you will have in the JVP is the X wave. What will happen to the X wave? X wave represents what? The atrial relaxation. Okay. So there will be reversal of the X wave. And another important abnormality that you will have is the Y wave. What is that abnormality in the Y wave you will have? That is early Y descent. That is what you will have in tricuspid regurgitation. Okay, so reversal of X wave and early Y descent is what you will have in tricuspid regurgitation. And in remaining all, you can have the presence of the giant A wave. Okay. C wave in JVP indicates LIMO. dominant Y wave, you see that in constrictive pericarditis and as well as the restrictive cardiomyopathy. That is where you will have prominent Y wave. Yeah, so C wave in the JVP, it indicates the bulging of the tricuspid valve, right? It indicates the bulging of the tricuspid valve into the right atrium upon right ventricular contraction. Now, yes, rod spots are seen in leukemia, uveal melanoma, starvation, aortic dissection. Right, so the correct answer is the leukemia. Now, you should know what are the differential diagnoses for the rod spots. Rod spots, you see that in patients with anemia, you see that in patients with leukemia, infective endocarditis, polyarteritis nodosa, then you see this rod spots even in hypertension, diabetes mellitus, okay, and even in sepsis. These are all the conditions where you can have the rod spots. What is that we learn until now? We see rod spots in infective endocarditis. What are these? These are nothing but retinal hemorrhages. Okay, apart from the infective endocarditis, these are all the other conditions where you can have the presence of the rod spots. Okay, right. See, your rod spot, it is immunological phenomenon. It is due to accumulation of antigen antibody complex within the retinal artery. There can be retinal artery rupture causing retinal hemorrhage, causing this rod spot. That is the mechanism of the rod spot. Yes, Limo and as well as GoPro with. Okay. Now, a one year old child with congenital heart disease is on heart failure treatment. The ECG of the patient shows all except. Right. So the ECG is not showing the ventricular bigeminy. Now, can anyone tell me which particular drug is this patient taking? Which particular drug is this patient or is this 1 year old child on for the heart failure treatment? So, this 1 year old child is on digoxin. So what are the points to tell that the individual is on digoxin? Number one, there is ST segment depression. And what is the morphology of the ST segment depression? It is like an inverted tick pattern. Right? It is an inverted tick pattern, or we also call it as the inverted mustache sign. So this inverted tick pattern or inverted mustache sign, it is very much suggestive of the digoxin effect. Very much suggestive of digoxin effect. And if you calculate the heart rate, roughly it is around 60 beats per minute. That is a true one. But what about the U wave? Yes, you are observing the U wave. The one which I am marking with green color, they are all the U waves. They are all the U waves. When can you have the U wave is whenever the patient has bradycardia, there can be appearance of the U wave. So this patient is having the U wave. Now digoxin, can it cause bradycardia? Yes, it can cause bradycardia by blocking the AV node. So because of that development of bradycardia, you have the presence of the U wave. Okay. So the correct answer here is the ventricular bigeminy is not seen. So the patient has not gone into a state of digoxin toxicity. The patient is in a stage of digoxin effect. Okay. Yes. In the JVP, Y descent is absent and X wave is prominent. What does this suggest? Restrictive cardiomyopathy, cardiac tamponade, constrictive pericarditis, right ventricular failure. Right. So the correct answer is the cardiac tamponade. Okay. In cardiac tamponade, you will have the X wave prominent and Y wave being absent. But whereas you take these two options, that is your A and as well as C, that is in restrictive cardiomyopathy and constrictive pericarditis, in both of these patients, you will have prominent X and Y wave. Right? You will have prominent X and as well as the Y wave. Okay. Whereas in right ventricular failure, as such, you will notice that the JVP is being elevated, and even you can observe the presence of the Kussmaul sign, which is being present. Kussmaul sign is present in all the three options, that is your A, C, and as well as D. But in cardiac tamponade, the Kussmaul sign is absent. Okay, so the answer here is B. Now we'll move on to one of the clinical scenario, and please tell me what is the management that you will do in this patient. A 75-year-old male patient presents to the AIMS emergency with retrosternal chest pain for 6 hours. The following ECG was done. What will be the primary management of the patient? The options are primary PCI, thrombolysis, APSIC-CMAP, low molecular weight heparin. So you should be able to identify what exactly is this ECG suggestive of. Now this patient is having the ST segment elevation and inverted T wave, right? ST segment elevation and as well as the inverted T wave from V2 to V4. That is suggestive of the development of anterior wall MI, and that too the patient has developed presented to the AIMS emergency within 6 hours, right? So within 6 hours, if the patient presents to you, what would be the ideal management for revascularization? That would be the primary PCI. That would be the primary PCI. That is the best method of the revascularization. And you take thrombolysis. That would be the second option for revascularization if the PCI facility is not there. Right? If the PCI facility is not there, then the second option would be the thrombolysis. And at this point, you need to know what is the door to needle time and how much should be door to balloon time. So if you are planning for thrombolysis, the door to needle time should be within 30 minutes. And if you are planning for PCI, the door to balloon time should be within 90 minutes. That means within 30 minutes of patient entering into the hospital, you should be able to do thrombolysis. And door to balloon time is what? Within 90 minutes of patient entering into the hospital, once you have decided to do PCI, within 90 minutes, you need to do the percutaneous coronary intervention. Okay, right. So only when PCI is not there, then we plan for thrombolysis. And after doing the thrombolysis, if the thrombolysis is failed, immediately you need to transfer the patient from non-PCI center to a PCI capable center. Immediately you need to shift the patient within 120 minutes, and immediately you need to get the PCI being done. Okay, right. So that was the question. Yeah, that is what Priya Thakur, I have said you, right? If the thrombolysis is being failed, then you shift the patient immediately to a PCI capable center and see that the PCI is being done. And very good, Mohammed, that is what is called as the rescue PCI. Okay, right. Now we'll move on to the next question. Okay, which of the following is the finding in the chest leads that you are noticing here? The options are myocardial ischemia, myocardial injury, digoxin effect, then digoxin toxicity. right? Digoxin effect and digoxin toxicity. Okay, so what is that you are observing here? That is the chest leads, that is from V1 to V6. So from V1 to V6, you are noticing that there is T-wave inversion. So if there is presence of T-wave inversion, what is it suggestive of? It is suggestive of the myocardial ischemia. Now in this patient, what is the treatment that you need to start? The treatment that you need to start is the antiplatelets is what you need to start. Along with that, you also need to start the statins. And if the patient has the pain, you also need to prescribe nitrates to the patient. Okay. Now, what will be the further follow-up of this individual? You need to do the cardiac biomarkers. If the cardiac biomarkers are positive in this individual, what is that you should consider? This patient, the cardiac biomarkers are positive. What is that you have to consider in this patient? So, if the cardiac biomarkers are positive, you have to consider it as the patient is having non-ST elevation MI, right? And these patients have to be started on the anticoagulants. That is, either you start low molecular weight heparin or you need to start the fondaparinux. Either of this you need to start. That is when your cardiac biomarkers are positive. Now, what are the other conditions where you can have the T-wave inversion? So, what is this basically? It's a T-wave inversion. Now, what are the other conditions where you can have T-wave inversions? T-wave inversions, number one, you can have it in myocardial ischemia. You will have T-wave inversion even in case of the bundle branch block, that is your RBBB and as well as left LBBB. And you also have that in RVH or LVH. So in left ventricular hypertrophy or right ventricular hypertrophy, you have asymmetrical T-wave inversion, which we call it as the strain pattern. In left ventricular hypertrophy, you will have T-wave inversion in V5, V6, and in right ventricular hypertrophy, you have the T-wave inversion from V1 to V3. And other condition where you can have T-wave inversion is pulmonary embolism. Because in pulmonary embolism, there will be increased afterload on the right ventricle, there will be right ventricular strain. So in V1 and V2, you have T-wave inversion in pulmonary embolism. The other condition where you can have T-wave inversion is in hypertrophic obstructive cardiomyopathy, where you will have T-wave inversion in the V5 and as well as the V6 leads. And what is that condition where you will have global T-wave inversion? Any one of you? Global T-wave inversion. And that too, there will be a giant T-wave inversion. Any one of you? Global giant T-wave inversion. So, global giant T-wave inversion is seen in patients with raised intracranial pressure. Yeah, Fawaz, it is not only subarachnoid hemorrhage. Any condition whichever is causing raised intracranial pressure, there will be giant global T-wave inversion. Okay, right. Now, let us try to discuss exactly the opposite ones. Yeah, what ECG finding is shown here? The hyperacute T-wave, T-wave alterance, T-wave inversion artifact. Yes, so this is suggestive of the hyperacute T wave. Now, what are the conditions where you can have the hyperacute T wave? There are two conditions where you can have hyperacute T wave. One is the hyperkalemia, right? And the other one is in case of the acute myocardial infarction. But what will be the difference between these two? In hyperkalemia, the T wave that is tall, it is the tall tented T wave in hyperkalemia. Whereas in acute MI, you will have broad tall T wave. Right? That is what is the difference between the T wave in case of hyperkalemia and as well as the acute MI. And in acute MI, this broad tall T wave that is considered or it is considered as the earliest manifestation in MI. Okay, so that was about the story related to the MI. Now we move on to the next one. Okay, a 50-year-old man develops an excruciating headache. On examination, the patient also has nuchal rigidity, and non-contrast CT performed after 4 hours show blood in the sylvian fissure. What does the ECG shows in this patient? T-wave inversion, artifact, premature ventricular complexes, positive U wave. Right, so the correct answer is giant T-wave inversion, and it is suggestive of what? It is suggestive of the subarachnoid hemorrhage. It is suggestive of subarachnoid hemorrhage. Okay. Now, in these patients with subarachnoid hemorrhage with raised intracranial pressure, you will have all the features of raised intracranial pressure. What all can be that? The patient can also have bradycardia. Right, the patient can also have the bradycardia. And what are the other changes? There can be a non-specific STT changes, and because of bradycardia there can be also presence of the U wave, which is not there, but because of bradycardia there can be even the appearance of the U wave as well. Okay, next. Yes, a 65-year-old man is brought with complaints of breathlessness and chest pain for 18 hours. ECG was done. Which of the following is incorrect in this patient? Normal sinus rhythm, normal axis, ST segment elevation in V2 to V4, premature ventricular contractures. Right, I'll just zoom this ECG, you tell me now. Normal, which of the following is incorrect? Normal sinus rhythm, normal axis, ST segment elevation in V2 to V4, premature ventricular contractures. Right, so the correct answer is D, that is premature ventricular contractures are not there. The remaining all you can see, you can have this rhythm. If you observe, there is normal RR interval, so it is considered as the normal sinus rhythm. And axis, if you observe, right, your lead 1 and lead 2, both of them like dominantly positive, which is considered as the normal sinus rhythm. And you take the ST segment elevation, it is present from V2 to V4, that is suggestive of the ST elevation MI. And which ST elevation MI? That is the anterior wall MI. And what is that you don't have in this patient is premature ventricular contractures, that is your option number 4 is not there. So premature PVCs are not there in this patient. Okay, right. And okay, what about the P waves? Yes, GoPro, you are having the P waves. Okay, so you can see here, this is a P wave. This is a P wave. P waves are present. P waves are present. This is a P wave. Okay, right. So the one which you are not seeing is the premature ventricular contractures is not, you're not seeing. Okay, right. Now we'll move on to the next one. Comment on the diagnosis of the ECG shown below. 2:1 block, trifascicular block, first degree heart block, the atrial fibrillation. So yes, very good, Sushant. So this is a QRS complex. You have a P wave, you have a P wave, then QRS complex, you have a P wave, you have a P wave, and then QRS complex. So this is suggestive of the 2:1 A block. Sorry, 2:1 block. Okay, right. Now we will move on to the next one. Okay. A 65-year-old patient of ST elevation MI underwent thrombolysis with streptokinase. The ECG tracing performed after thrombolysis is shown below. What does it exhibits? It exhibits ventricular bigeminy, accelerated idioventricular rhythm, ventricular tachycardia, Wenckebach's phenomenon. Right. So this is the ECG, very much suggestive of accelerated idioventricular rhythm. Now, what are the changes that you will have in the ECG of accelerated idioventricular rhythm? See, to call it as AIVR, what is another name for AIVR? This is also called as reperfusion arrhythmia. So there should be a classical history of an individual undergone thrombolysis, and these reperfusion arrhythmias are those which are originating from the reperfused myocardium, that is from the ventricle. So that is the reason why P wave will be absent in case of the reperfusion rhythms or in case of accelerated idioventricular rhythms. And the heart rate, it will be mostly bradycardia, that is what you will observe. Now, because these are the rhythms which are originating from the ventricle, how will be the QRS complexes? They will have the wide QRS complexes. Right, they will have the wide QRS complexes. These are the ECG changes that you will have in case of accelerated idioventricular rhythm, okay, which is nothing but the reperfusion arrhythmia. And these are benign rhythms, right? These are benign rhythms. So they are like self-limiting. After a while, these rhythms, they return back to normal. All right. Next. Venkatesh, is 2:1 block a type of Mobitz type 2 block? It is not exactly. Right, it is not exactly. Why? Because you take in case of 2:1 block. In case of 2:1 block, for every 2 P waves you will have one QRS complex. That should be there definitely. This is definite, okay, mandatory. But whereas in case of Mobitz type 2 AV block, it is only the PR interval that will be constant, but the QRS which is being dropped, it occurs intermittently, and there is no pattern which is being followed. Right, the QRS which is being dropped, it occurs randomly or intermittently. There is no pattern which is being followed. Yes, Venkatesh, did you understand this point? Okay. Now, after having discussed about this AIVR, yeah, you take this next question and we'll try to solve this. Okay. A 60-year-old patient is having recurrent syncopal attack post myocardial infarction. The ECG is being done. What is it suggestive of? What is it suggestive of? Yes, right. So this is the ECG suggestive of the Mobitz type 2 AV block, right? It is not progressive lengthening of the PR interval that you are observing here. The PR interval, it is constant, right? The PR interval, it is constant here. So how much ever is the PR interval here? The same PR interval you are seeing here also. The PR interval is constant. But intermittently you are noticing that there is drop in the QRS complex. Right, intermittently you are noticing that there is drop in the QRS complex. So which is suggestive of Mobitz type 2 AV block, right? So now you see here, Venkatesh, Mobitz type 2 AV block, is it following your 2:1 block? It is not following your 2:1 block. So that is the reason why your Mobitz type 2 AV block and 2:1 block, both of them are not same. Okay, right. Now we'll move on to the next question. Okay, so this patient, a 35-year-old female, presented on, the patient is on amitriptyline. He is brought in to the casualty with suspected intentional overdosage. On admission, the blood pressure is 80 by 60 millimeters of mercury, GCS 5 by 15. She was intubated and ECG was performed. Which of the following is the correct ECG interpretation and management of the patient? Very good. So what is it suggestive of? Now this patient is having the ECG which is suggestive of wide QRS complexes, right? ECG is showing the presence of the wide QRS complexes. Okay, broad QRS complexes. Along with that, there is also ST segment elevation which is present in V1 and as well as V2. Where do you come across this in the patient's clinical scenario? You come across this in case of tricyclic antidepressant toxicity. In tricyclic antidepressant toxicity, you will have wide QRS complexes and ST segment is elevated in V1 and as well as V2. Now, in tricyclic antidepressant toxicity, just remember the individual is at increased risk of development of acidosis. Right? The patient is at increased risk of development of the acidosis. Okay. Now, in order to correct the acidosis, you need to give the sodium bicarbonate. In order to correct the acidosis, you need to give sodium bicarbonate. And usually, when do we give this sodium bicarbonate is, we need to do ABG in the patient. Now, in the ABG, if the pH, if it is less than 7, that is the indication of giving the sodium bicarbonate. Okay, right. So, the answer is A in this patient, right? Now, we'll move on to the next clinical scenario. Right, these are all your PYQs. So, a 50-year-old woman with rheumatic heart disease is on medication for heart disease. She feels unwell most part of the day. Which of the following medicine should be prescribed for condition shown below? ACE inhibitors, diuretics, ivabradine, digoxin. Now, I'll just zoom this ECG. Now, tell me which drug you want to give. ACE inhibitor, first option. Diuretic, second option. Ivabradine, third option. Fourth option, digoxin. What is that you want to give in this patient? Okay, good. So what is that you have to give in this individual is the digoxin. Why is that you have to give digoxin? This patient, can anyone tell me what is the diagnosis of this ECG? Now, what is the diagnosis? Right. So if you closely observe the diagnosis, or if you closely observe the ECG, very good. So this is the ECG suggestive of the atrial fibrillation. Why is that you are telling atrial fibrillation? Because if you see the rhythm of the ECG strip, you have an irregular rhythm. There is variable RR interval and the P waves, they are absent. Instead of that, you have what is called the fibrillatory wave. So this is suggestive of your atrial fibrillation. So in atrial fibrillation, the drug that you need to give to make the individual normal is the digoxin, because digoxin, it is one of your AV blocking agent. Okay, AV nodal blocking agent. Now you move on to the next question. Right. A 25-year-old soldier is trapped in an avalanche in Siachen Glacier. He is airlifted to the base hospital. On admission, the pulse is steady and blood pressure is unrecordable. ECG strip is shown below. All of the following findings are seen except. Right. So what is that you are not able to see in this is your the patient is having the Osborne wave. What is that you are not able to see is the atrial bigeminy. right? So this patient has been trapped in avalanche. What the patient can develop? That is the hypothermia. Now, whenever there is hypothermia, the ECG finding that you will observe or you will see is the Osborne wave. Now, what is this Osborne wave? It is a blip which is present at the J point. And this is what is the Osborne wave, which is seen in patients with the hypothermia. And in patients with hypothermia, the other ECG changes that you can have is there can be bradycardia, which is present in this patient. And along with that, ST segment, if you clearly notice, you have a concave ST segment elevation. So the ECG changes in hypothermia will be bradycardia, ST segment elevation, and appearance of the Osborne wave. These are the points which are suggestive of the hypothermia ECG. Okay. Next. Right. Sushant, in case of COVID pattern, this is what is your COVID pattern, right? The point how you have to differentiate is, in case of Osborne wave, you have this blip, and this blip is nothing but the Osborne wave. Okay, right. What does the following ECG shows? Osborne wave, delta wave, hockey stick sign, the epsilon wave. Right. So it is suggestive of the hockey stick sign. So the presence of hockey stick sign, what is it suggestive of? Very good, Misty. It is suggestive of digoxin effect. What is the condition where you will have epsilon wave? What is the condition where you will have the epsilon wave? That is in arrhythmogenic right ventricular dysplasia. That is where you get this epsilon wave. Now, what is the investigation of choice in case of the arrhythmogenic right ventricular dysplasia? Yes, what is the investigation of choice in arrhythmogenic right ventricular dysplasia? Yes, Sushant? Very good. That will be cardiac MRI. What will be the treatment of choice? Not Holter, it is cardiac MRI, which will show the right ventricular dysplasia. What is the treatment of choice? No, the treatment of choice will be placement of ICD, implantable cardioverter defibrillator, because this ARVD is arrhythmogenic right ventricular dysplasia. Okay, so it is highly arrhythmogenic right ventricle. So you place an ICD, right? Okay, next question. A 20-year-old student collapsed while running after a bus to college. Which of the following wave is shown in the patient? Right, that is your delta wave. Which has been shown to you is the delta wave. Okay, now in this patient, what is the name of the accessory bundle? Yes, what is the name of the accessory bundle? Yes, so that is the bundle of Kent. That is bundle of Kent. Next. Okay, very simple and easy, very simple ECG, and you should not miss the diagnosis at all. Any one of you? Right. So you have this classical sawtoothed pattern P wave, right, which is suggestive of the atrial flutter. Very simple and a very easy question. Okay. One more simple and easy question, which where you should not miss the diagnosis at all. So this ECG, it is suggestive of monomorphic, right, monomorphic ventricular tachycardia, right, monomorphic ventricular tachycardia, where you have the wide QRS complexes, and the QRS complexes duration, if you see, it is like more than 160 milliseconds. And in the ECG of VT, what are all the things that you need to observe? Apart from your wide QRS complexes, there can be presence of the capture beats, there can be presence of the fusion beats, right, and there can be presence of the two important signs. What are those two important signs? One is the Brugada sign and the other one is the Josephson sign. Okay, so these are the two important signs that you can have in the ECG of a monomorphic ventricular tachycardia. Now, another simple quick recap ECG is, which of the following is seen in the ECG shown below? First degree heart block, Mobitz type 1 heart block, Mobitz type 2 heart block, third degree heart block. Right, so this is the ECG which is suggestive of the Mobitz type 2 heart block. So what is that you are able to notice? The PR interval is constant, but there is intermittent drop in the QRS complex. So this is suggestive of your Mobitz type 2 AV block. This is the repeat ECG again. Okay, comment on the diagnosis in the ECG given below. RBBB, LBBB, trifascicular block, Mobitz type 2 heart block. Yes, right. So you are having number one wide QRS complex. Along with wide QRS complex, what is that you are noticing? You are noticing that there is deep, wide, right? Deep, wide S wave in V1. And you are noticing that there is broad, tall R wave in V6. So this is suggestive of, right, this is suggestive of the left bundle branch block, and exactly the opposite what you will have in the right bundle branch block. All right, next. Yeah, a 60-year-old smoker developed severe chest pain since 6 a.m. in the morning. On admission at 7 a.m., the cardiac enzymes were normal and ECG is as follows. Which coronary artery of the patient is blocked? I've just zoomed the ECG. The options are left anterior descending artery, first option, left circumflex artery, second option, right coronary artery, third option, fourth option is posterior descending artery. So, which vessel is blocked in this patient? Right. So, not right coronary artery, it is the left circumflex artery. Right, it is the left circumflex artery. So, what is that you are noticing here is you are observing that there is an ST segment elevation, that is concave ST segment elevation in lead 1 AVL V5 V6, which is suggestive of the lateral wall leads, which is supplied by the left circumflex, which is supplied by the left circumflex. Okay, so the answer is B. Now we move on to the next question. Okay, the patient with myocardial infarction has dyspnea grade 4. The pulse rate of the patient is 120 beats per minute, and the blood pressure is, right, the blood pressure is 220 by 120 millimeters of mercury. Chest X-ray of the patient is shown below. All of the following are indicated here except thrombolysis, aspirin, morphine, furosemide. Sushant, if you have ST segment elevation only in one lead, that is lead 2, can you consider it as inferior wall MI, Sushant? How many leads at least it should have been elevated more than or equal to 2 contiguous leads. And if you have ST segment elevation only in lead 2, you cannot consider it as the inferior wall MI. Right. So this patient, you should not give thrombolysis. Now, what is it suggestive of? Okay. First of all, you should not give thrombolysis because if systolic blood pressure, if it is more than 180 millimeters of mercury, then it is thrombolysis is contraindicated if the systolic blood pressure is more than 180. Our patient is having a blood pressure of 220, so never you do thrombolysis. Morphine, it can be given in case of MI because morphine will reduce the preload on the heart and thereby it can reduce the pulmonary edema. Actually, what is the diagnosis? Here you have this classical back wing appearance, which is suggestive of the pulmonary edema. So morphine can be given comfortably because that will reduce the preload on the heart. So thereby morphine can be given. And aspirin, it should be given as a part of the treatment for the myocardial infarction. And furosemide, it will reduce the cardiogenic pulmonary edema, for which you need to give the furosemide. Furosemide has to be given in this patient. Now you see the next question. Okay, so the chest X-ray which has been given, what is the diagnosis? Dextrocardia, pneumothorax, pneumomediastinum, pulmonary hamartoma. Yes, any one of you? Right. So this is very clearly suggestive of the dextrocardia. This is very clearly suggestive of the dextrocardia. So you can see the apex of the heart which is being present on the right side, and you can also notice the trachea is being shifted to the right side, which is suggestive of the dextrocardia. Yeah, so this is the ECG of the situs inversus. This is the ECG of the situs inversus. Okay, right. Now you see the next question. Which of the following is incorrect about the image which has been shown below? Yes, right, very good. See, this patient is having clubbing. Now, where is that you will have the clubbing? You will have this clubbing in case of which cardiac condition? That is in cyanotic congenital heart diseases. Now, if the patient has to develop the cyanotic congenital heart diseases, the shunt, whatever is there, it should be from right to left. The shunt should be from right to left. It is not the left to right. Left to right shunt will not cause the clubbing. Where do you have left to right shunt? In ASD, VSD and as well as the patent ductus arteriosus. So in left to right shunts, please remember you don't have this clubbing at all. Okay. And what about the other investigations? Yes, the Shamrock test, right? It should be done, which will be positive. It is seen in suppurative lung diseases like lung abscess, and there will be loss of Lowy bond angle. And how much is the normal Lowy bond angle? Yes, how much is the normal Lowy bond angle? What is Lowy bond angle? It is the angle between the nail bed and as well as the nail plate. That is, yes, how much is the normal Lowy bond angle? So if you observe the normal Lowy bond angle, no, it is not 180 degrees. It is not at all 180 degrees. Very good, Venkatesh. So if you see the angle, it is around 160 degrees. The normal Lowy bond angle is around 160 degrees. Okay, right. Then, and Shamrock test, what is that you need to do? Like you need to approximate both the digits or both the thumbs together, and you have to look for the presence of this diamond shaped space between the two thumbs. And if there is obliteration of this diamond shaped space between the two digits whenever you have approximated, that we call it as the Shamrock test is being positive. Okay, right. Then yeah, you see the next question. The child shown below has which heart disease? Endocardial cushion defect, partial anomalous pulmonary venous connection, patent ductus arteriosus, tetralogy of Fallot. So how is the appearance of the child? The appearance of the child is that the individual or the child is having a saddle nose. Can anyone tell me what is the diagnosis? Child is having the saddle nose, but the eyes are actually masked. But if you see there is a mongoloid slant of eye. Now this saddle nose and mongoloid slant of eyes, this is suggestive of Down syndrome. Right, this is suggestive of the Down syndrome. Now in case of Down syndrome, what are the cardiac abnormalities that you will come across? The cardiac abnormalities that you will come across in case of the Down syndrome is, number one, atrial septal defect. Then that too, which type of atrial septal defect? Ostium primum type of atrial septal defect. The other thing is there can be endocardial cushion defects. Right, endocardial cushion defect. So the correct answer here is the endocardial cushion defect. Yeah, very good, Ankit. So the most common is the endocardial cushion defect. Okay, right. Now you see the next ECG. Right, a martial arts exponent complains of dizziness and syncopal attack. The ECG has been done in this martial art exponent, and ECG tracing has been given below. What is the diagnosis suggestive of? Mobitz, first degree heart block, Mobitz type 1, Mobitz type 2, and third degree heart block. No. It is not. I'll just zoom this ECG. Yeah, now you answer. Very good, Spandana. So that will be Mobitz type 1. Mobitz type 1. So you can see here clearly that there is progressive prolongation of the PR interval. And at one point of time, you have a P wave, but there is no QRS complex. So this is very classically suggestive of the Mobitz type 1. And I will show you one more ECG. Right, answer this. Identify the abnormality in the ECG shown below in a lady suffering from interstitial lung disease. P pulmonale, P mitral, PSVT, S1Q3 T3 pattern. Yes. So this is the ECG suggestive of, yeah, it is the P pulmonale. See, when the patient is developing, when the patient has interstitial lung disease, they develop the cor pulmonale. And as a part of the cor pulmonale, there is pulmonary hypertension causing increased afterload on the right ventricle. Right, there is increased afterload on the right ventricle. So this will cause increase in your right ventricular pressure. This will cause increase in the right atrial pressure. Now as the right atrial pressure is being elevated, there can be right atrial hypertrophy, which will cause the P pulmonale. Which will cause the P pulmonale. So you take this P pulmonale. What is the criteria to call it as the P pulmonale? So the criteria to call it as P pulmonale in the limb leads, that is, the height of the P wave should be more than 2.5 mm in the limb leads. What should be the amplitude of the P wave in the chest leads? So in the chest leads, the height of the P wave, it should be more than 1.5 mm. It should be more than 1.5 mm. Okay. And what are the various causes of P pulmonale? One is your pulmonary hypertension, where you can have P pulmonale. The other conditions where you can have P pulmonale is the tricuspid stenosis. And you can also have this in tetralogy of Fallot with pulmonary stenosis. These are all the conditions where you will have the P pulmonale. Okay. Right. Now we'll move on to the next question. Yes. Which of the following condition can be a probable diagnosis for the JVP recording mentioned below? Constrictive pericarditis, cardiac tamponade, cor pulmonale, cor triatrium. Right? Yes. I'll just zoom this JVP finding. Please try to tell me in which condition you can have this. See, you are having prominent Y wave and you are having prominent X wave. So prominent Y wave and prominent X wave in the JVP, it is seen in constrictive pericarditis and it is seen in restrictive cardiomyopathy. Now what is the answer here? That is the constrictive pericarditis. The constrictive pericarditis. Okay, right, just 1 minute. Just give me a minute, that's all. Right. So you see the next question. What is the feature of the temporal arteritis? Giant cell arteritis, granulomatous vasculitis, necrotizing vasculitis, leukocytoclastic vasculitis. Actually, you have two options which are being correct in this. Okay. So very simple and easy question. One is your giant cell arteritis and very good Priya Thakur, even granulomatous vasculitis. But the next question is very, very important. Right. Yeah, please answer this. Giant cell arteritis cause which of the following abnormality within the eye? Yes. Yes. In case of giant cell arteritis, the patient can have sudden onset blindness, and that is because of the involvement of posterior ciliary branch of the ophthalmic artery, right? And what exactly happens is that is development of the anterior ischemic optic neuropathy. That is what will happen in the eye of an individual with the giant cell arteritis. That is anterior ischemic optic neuropathy. Okay, next. What is the true about giant cell arteritis is all except high dose of steroids is the drug of choice, ESR is usually raised, intracranial internal carotid artery is particularly susceptible, mainly affects the people of more than 50 years. So, which is the incorrect statement? The incorrect statement is the intracranial internal carotid artery is particularly susceptible is the wrong statement. Otherwise, in giant cell arteritis, what is the drug of choice? That is your high dose steroids. And ESR is being elevated because it's a vasculitis. And the age group at which you see this temporal arteritis, it is commonly more than 50 years of age. But whereas you take in case of the Takayasu arteritis, in Takayasu arteritis, the age group at which you see is less than 50 years, right? In Takayasu, it is less than 50 years, okay, right? And let me just show you one more important question, right? The jaw tightness, it is typically seen in polyarteritis nodosa, coarctation of aorta, giant cell arteritis, Wegener's granulomatosis. Right. So the correct answer is the giant cell arteritis. So what is this jaw tightness? It is nothing but the jaw claudication. Why is that you are having jaw claudication in case of giant cell arteritis? That is because of the involvement of the temporal artery. So once there is temporal arteritis, the perfusion to the muscles of mastication will be reduced, and that is what is responsible for the jaw claudication, right? Next. Then, yeah, just 1 minute. Yes. Granuloma is the pathological feature of all of the following forms of vasculitis, except in which of that you don't have the granuloma formation. Right, that is the microscopic polyangiitis. Giant cell arteritis, Wegener's granulomatosis, Church-Strauss syndrome, and as well as your Takayasu arteritis. So in all of this, the type of vasculitis is the granulomatous inflammation. Whereas in your microscopic polyangiitis, it is non-granulomatous vasculitis or necrotizing inflammation is what you will see in case of the microscopic polyangiitis. Then, okay, very simple and easy question. C. anca is found in, right? C. anca is found in, right? That is in Wegener's granulomatosis. And at the same time, if you see the P. anca, it is present in microscopic polyangiitis, Church-Strauss syndrome, and as well as the Good-Pasteur syndrome, whereas the C. anca, it is found in the Wegener's granulomatosis, right? Then, now the next question, okay, so this was one more type of questions which have been asked previously. Okay, let me see how many of you can answer. The assertion and reason questions were asked previously. The assertion is that Raynaud's phenomenon may be associated with hypothyroidism. Reason, the typical sequence of vasospasm followed by arterial constriction and denaturation of the hemoglobin. Okay, vasospasm, arterial constriction, and denaturation of the hemoglobin. Now tell me which is the correct answer in this. Right, very good. Yeah, so that is your option C. Now A is correct, the assertion is correct. That is, Raynaud's phenomenon is a clinical syndrome seen in patients with the hypothyroidism, right? So this assertion is correct, but whereas you take the sequence in the Raynaud's phenomenon, the sequence in Raynaud's phenomenon, it is the PCR, right? What is this PCR? P stands for pallor. That means here there is arteriolar constriction, right? C stands for cyanosis. That means here at this point there is desaturation of the hemoglobin, okay, because of which there is blue, followed by that the redness. P stands for pallor, C stands for cyanosis, R stands for redness, and redness, it is due to vasodilatation. So that is the reason why your reason which has been given is correct, incorrect. Whereas A, that is Raynaud's phenomenon may be associated with hypothyroidism, is correct answer. And what are the other conditions where you can have the presence of the Raynaud's phenomenon? The other conditions where you can have Raynaud's phenomenon is in patients with the scleroderma. That is a very, very important condition. And the other conditions are dermatomyositis. You can have that in systemic lupus erythematosus and rheumatoid arthritis as well. Okay, right. So that is about the reason and as well as assertion type of questions which have been asked previously. Yes. Mitral valvotomy is indicated in symptomatic mitral stenosis when the mitral valve orifice is less than. Mitral valvotomy is indicated in symptomatic mitral stenosis with mitral valve orifice less than. Right. So the correct answer is in case of severe mitral stenosis. Okay. So this is considered as severe mitral stenosis, and this is considered as very severe mitral stenosis. So in severe mitral stenosis, if the patient is having symptoms, it's an indication for doing the mitral valvotomy. And what is that form of the mitral valvotomy that you can do? There are two techniques. Now, what is this particular technique which is being shown in the image here? What is the technique which is being shown in the image here? So this technique, it is the percutaneous balloon mitral valvotomy. So this is your PBMV. This is your PBMV, percutaneous balloon mitral valvotomy. So this percutaneous balloon mitral valvotomy, it is the procedure which is being done through the vessel. So we puncture the the femoral vein. Through the femoral vein, we enter into the inferior vena cava. From the inferior vena cava, like we enter into the right atrium, and from the right atrium we puncture the interatrial septum, and after puncturing the interatrial septum, we pass the balloon across the mitral valve and we open the mitral valve by opening the balloon. And the name of the balloon which is being used is, it is called the Inno balloon. And the other method of doing the valvotomy is the surgical valvotomy. Right, the other one is the surgical valvotomy. Now, what are the contraindications for the PBMV? Right, yes, Priya Thakur, I am about to discuss the contraindications. So the contraindications for PBMV is, number one, calcific mitral stenosis, we don't do the PBMV. If there is presence of left atrial thrombus, we don't do the PBMV. And if there is presence of moderate to severe mitral regurgitation along with mitral stenosis, then also we don't do the PBMV. Okay, so these are the contraindications for doing the PBM, right? Now, accordingly, let me just ask you a question. Understand the question properly, then you answer. Absolute contraindication for PBMV includes all of the following except. So here the question which is being asked is the one which is testing your knowledge of English rather than testing the knowledge of general medicine. Right. So the correct answer is the presence of pulmonary hypertension. So there are two negatives which are given here. Absolute contraindication. Okay, that is one negative. Except is another negative. Okay, except is another negative. So you see the question now. Percutaneous balloon mitral valvotomy can be done in pulmonary hypertension. But whereas this percutaneous balloon mitral valvotomy, these three conditions just now I have taught you, they are contraindications. So try to understand the English language in the question. Absolute contraindication except. These three are your absolute contraindications. But what is asked? Except. That is your pulmonary hypertension. So if there is, now in patients with mitral stenosis, there can be development of pulmonary hypertension. Why is that? That is due to backflow of the blood. So due to backflow of the blood, there can be development of pulmonary hypertension. And if you open the valve with the balloon, the pulmonary hypertension can be reduced. Why? Because from the blood from left atrium will move into left ventricle once you open the valve with the balloon. Thereby the backflow will be reduced and pulmonary hypertension can be reduced. Okay. So the correct answer is A. Right. Yeah, so right, this is the question which is being given mainly to test your knowledge of English. Right, next is the syndrome which represents a subset of the Carney complex is the name syndrome, Leopard syndrome, Merff syndrome, Wilkes syndrome. Okay, so the syndrome which represents the subset of the Carney complex is the name syndrome. It is the name syndrome. What exactly is that? I will discuss. Okay, so there are two syndromes which represents the subset of the Carney complex. One is the name syndrome. The other one is the Lamb syndrome. Right? The other one is the Lamb syndrome. So approximately 90% of myxomas, they are sporadic. The remainder is familial with the autosomal dominant transmission. In Carney complex, what will be the your subset of the Carney complex? The subset of the Carney complex is number one, you have the myxoma, that is cardiac myxoma or cutaneous myxoma or the myxoma within the breast. And the other important subset is the presence of the lentigenes, or there could be presence of the pigmented nevi. And third important is the endocrine overactivity. Right? The third important is the endocrine overactivity. So, and these are the things that you will see in the Carney complex. Now, what do you understand this by word name? In this name, the word N stands for the nevi, right? Nevi. The word A stands for the atrial myxoma. The word M stands for myxoid neurofibroma, right? Myxoid neurofibroma. And the word E stands for aphylides. The word E stands for the aphylides. So this is what is your name. Okay. Now what do you understand by this word Lamb syndrome in case of atrial myxoma? In Carney complex, the word L stands for the lentigenes. The word A stands for the atrial myxoma. The word, that is your LAM, atrial myxoma. The word B stands for the blue nevi. So these two syndromes, name syndrome or the Lamb syndrome, they are the one which will represent the subset of the Carney complex. What about the Leopard syndrome? Leopard syndrome is an inherited condition characterized by abnormalities where all you can have abnormalities within the skin, you can have the abnormalities within the heart, you can have abnormalities within the inner ear and as well as the genitalia, right? Inner ear and as well as the genitalia. Okay, so that is what is the Leopard syndrome, right? And the next is the Murph syndrome. Murph syndrome, it is a mitochondrial disease. It is a mitochondrial disease and it is extremely rare, and the patient has varying degree of expressivity owing to heteroplasmy, right? That is, in Murph syndrome, the different parts of the body, particularly the muscles and nervous system, are being affected. That is what is your Murph syndrome. It's a mitochondrial disorder. What is Wilkes syndrome? The Wilkes syndrome, it is the duodenal obstruction. Right? It is the duodenal obstruction that can easily be missed at the clinical practice. And Wilkes syndrome, it is characterized by nausea, abdominal pain, and as well as the vomiting. And where exactly will be the obstruction? That will be at the level of the duodenum. That is what is your Wilkes syndrome. So remember, the subset of the Carney complex will be the name syndrome and as well as the Lamb syndrome. Okay, right. Okay, now right, so let me discuss the next question. Yeah, all are the causes which predispose to Staphylococcus aureus infection except eczema, insect bite, lichen planus, injections, especially the insulin. All are the causes which predispose to Staphylococcus aureus infection except right. So the correct answer is the lichen planus. So you should know what are the factors that predispose to the Staphylococcus aureus cutaneous infection. Number 1, eczema. Number 2, the insect bite. Number 3, injections, especially in diabetic patients. Number 4, poor personal hygiene. That is also the predisposing factor for the Staphylococcus aureus infection. And then chronic skin conditions, they are also the one which can predispose to the development of your Staphylococcus aureus infection. Now, one of the Staphylococcus aureus infection is the infection involving the hair follicle, where there can be development of the folliculitis. Okay, you see, this is the image of the folliculitis. Right, so folliculitis, it is a superficial infection involving the hair follicle with the central area of purulence surrounded by the induration and as well as the erythema. Right, so this is one thing that you need to be very much aware of. Okay, next. Okay, photosensitivity is the feature of the porphyria. Now, lichen planus, even though it is a chronic skin condition, you don't have the infective pathology in case of the lichen planus. So that is the reason why your Staphylococcus aureus is not a predisposing factor there. Okay, right. So photosensitivity is the feature of porphyria. All the following enzyme deficiencies have photosensitivity as manifestations except hydroxymethyl-bilane synthase deficiency, uroporphyrinogen decarboxylase deficiency, protoporphyrinogen oxidase deficiency, coproporphyrinogen oxidase deficiency. Where is that you don't have the photosensitivity? Very good. That is, in case of the hydroxymethylbelane synthase deficiency, you don't have this photosensitivity. Now, this enzyme, that is your HMB synthase, what will be the presentation in this individual? There will not be photosensitivity, but what will be the presentation in case of the HMB deficiency? That is the abdominal pain. Abdominal pain is the most common manifestation of this HMB deficiency, but photosensitivity, you don't see that. The remaining all can cause the photosensitivity as such. Okay, right. One more clinical scenario, let me show you here. Okay, so little lengthy clinical scenario, but very simple to answer, not at all a difficult one. A 52-year-old woman is taken to the hospital because she has become completely paralyzed. Very important emergency, okay? Completely paralyzed. By the time she is examined, the paralysis has begun to clear and it has completely resolved after 1 hour. Okay, you see that change? Within 1 hour, the paralysis has been resolved. She states that she has had previous episodes of severe transient weakness, but that this was the first time that she felt unable to move. This is the first time where she was unable to move completely. But previously also there was like transient weakness. She has also been experiencing paresthesias. On physical examination, blood pressure is 160 by 100, serum sodium 155, potassium 2.8, decreased serum renin. Which of the following is the most likely diagnosis in this patient? Right, so this is a very clear-cut picture of hyperaldosteronism. Right, so what is the clinical scenario where you can have the hyperaldosteronism here? That is the Conn syndrome, which is nothing but your primary hyperaldosteronism. So these patients, they will have hypokalemia, and it is the hypokalemia which will be causing this episodic weakness. It is the hypokalemia which will be causing paresthesia. It is the hypokalemia which will be causing the transient paralysis. Whereas in Cushing syndrome, the patient will have what? The moon faces, truncal obesity, buffalo hump, abdominal striae. That is what you will have in Cushing syndrome. And Mallory-Weiss syndrome is what? Mallory-Weiss syndrome, it is the laceration. Right? It is the laceration of the lower end of the esophagus. And this particular laceration which is present at the lower end of the esophagus, it is induced by the severe vomiting. It is the severe vomiting which is causing the laceration. Then what is this May-White syndrome? May-White syndrome, it is a form of familial progressive myoclonic epilepsy. Right? It is a form of familial progressive myoclonic epilepsy. Right? Along with this epilepsy, this May-White syndrome, the other manifestations are, they will have lipoma, they can have deafness, and they can also have ataxia. These are the features that you will have in case of the May-White syndrome. Okay, right. So this is about the Conn syndrome, the clinical scenario. Now, one more question I'll give you, like you need to combine which are all the true statements. Right. About the cardiac manifestations of the carcinoid syndrome, tell me which are true, which are false. The A is the cardiac disease in carcinoid is due to formation of fibrotic plaques involving the endocardium. Okay. And B is the fibrous deposits are most commonly on the ventricular aspect of the tricuspid valve. C is cardiac failure is not the feature of the carcinoid syndrome. D is the lesions on the left side are extensive and most frequently affect the mitral valve. So which are the true statement, which are the false statements? Right. So your A and B are true. That is your right. The fibrotic plaques are the one which are involving the endocardium in case of the carcinoid, and that too which side? Mainly the right side. And fibrous deposits are most commonly on the ventricular aspect of the tricuspid valve, and that will result in the tricuspid stenosis, or there can be tricuspid insufficiency. That is also the true statement. Cardiac failure is not the features of the carcinoid syndrome. No, almost, right, almost 80% of patients with the carcinoid syndrome, they develop the right heart failure. And lesions on the left side are extensive and most frequently affect the mitral valve. It is an incorrect statement. See, on the left side, right, on the left side, the lesions are less extensive in case of the carcinoid syndrome. Right, they are less extensive in carcinoid syndrome. So that is the reason why your A and B are true, whereas C and D are the false statements. Okay, right. A 35-year-old female has proximal muscle weakness, ptosis, and easy fatigability. The most sensitive test to suggest the diagnosis is muscle biopsy, CPK level, hydrophonium test, single fiber electromyography. Pushpendra, why there is right heart failure is because these patients with carcinoid syndrome, they develop tricuspid regurgitation or they develop pulmonary stenosis. Because of tricuspid regurgitation or pulmonary stenosis in carcinoid syndrome, they can develop right heart failure. Okay. Right. So the diagnosis of this patient is the myasthenia gravis. So in myasthenia gravis, what is the investigation of choice? That is single fiber electromyography. That is the investigation of choice in patients with the myasthenia gravis. Okay. And your hydrophonium test, CPK level, muscle biopsy, they are not most sensitive. Among all these, the most sensitive is single fiber electromyography. And what is the other name for the hydrophonium test? So the other name for the hydrophonium test, it is also called as the tensilon test. Once you inject this hydrophonium or tensilon, the ptosis whichever is there will disappear in this individual. Okay, your hydrophonium is nothing but your acetylcholine esterase enzyme inhibitor, which can increase the acetylcholine levels. But whenever you are doing the tensilon test, what is the drug that you need to keep? Okay, what is the drug that you need to keep available is the atropine. So atropine should be ready for you. Okay, right. So that is about your tensilon test. And one more test, the very important test for the myasthenia gravis is the ice pack test. Right, it is the ice pack test. So ice pack, whenever there is application of the ice pack on the eye where there is ptosis, remember on application of the ice pack there will be increased neuromuscular transmission. So once there is increased neuromuscular transmission, the ptosis will disappear. That is what is the ice pack test. Okay, right. One more question on the topic of the POEM syndrome. This is one important area where the questions can be asked. Regarding the POEM syndrome, which of the following is true and which of the following is false? You take A, B, C, D. E, organomegaly is described as a feature of POEMs. That is one. B, patients usually have a severe progressive sensory motor neuropathy, polyneuropathy. Third, type 2 diabetes mellitus occurs in about 1/3 of patients. Fourth, amenorrhea in women, impotency and gynecomastia in men is seen. Fifth, lymphadenopathy, although rare, resembles the Castleman disease histologically. So here, just remember your B, C, D and E. These are the true statements and A is the false statement. A is the false statement. Okay. Now first of all, okay, let me try to discuss each and every option. Poems. What does this poems stands for? Right. This poems, the word P stands for polyneuropathy. The word O stands for organomegaly. The word E stands for endocrinopathy. Right? The word M stands for multiple myeloma. The word S stands for the changes within the skin. The changes within the skin. Now, what about this organomegaly? This organomegaly, whichever is there, it is not rare. Organomegaly is described as a feature, but rare in Poem syndrome is a wrong statement. This organomegaly, that is hepatomegaly, lymphadenopathy, splenomegaly, they are all present in almost two-thirds of patients with the Poem syndrome. It is not a rare manifestation. So that is the reason why your A point is wrong, incorrect statement. And they will have neuropathy, polyneuropathy, and the type of polyneuropathy is the sensory motor polyneuropathy, right? And type 2 diabetes mellitus occurs in one-third of patients. Yes, that is the correct statement. And you take endocrinopathies. Yes, amenorrhea will be there in women, whereas in men there is impotency and as well as the gynecomastia. What about lymphadenopathy? Lymphadenopathy is rare and resembles the Castleman's disease the histologically. Right? So, what is this Castleman disease the histologically? So, this Castleman disease is that a condition that has been linked to interleukin 6 overproduction. Right? There is interleukin 6 overproduction. That is what is the Castleman's disease. And this Castleman disease, it is a rare disease that involves the overgrowth of cells in your body's lymph node. So there will be overgrowth of cells in your body's lymph nodes. That is what is the Castleman disease. And the most common form of disorder affects a single lymph node, usually in the chest or in the abdomen. Now you should know what is the organism that is responsible for your Castleman disease. It is associated with the viral infection, that is the HHV8 and as well as the HIV. Okay, so now, so remember now, your for A point is false statement. The remaining all which have been given are the true statements. Okay, so that is about your Poem syndrome, right? And few more, one or two questions we'll discuss and then wind up. Okay, what is the most common type of renal tubular acidosis? Type 2, type 4, type 3, type 1. Which is the most common type of renal tubular acidosis? So the most common type of renal tubular acidosis is, that is type 4, which is characterized by hyporeninemic, hypoaldosteronism. Okay, so type 4 is the most common type of the renal tubular acidosis. So basically there is aldosterone deficiency or aldosterone resistance. Aldosterone deficiency or aldosterone resistance. That is what is your type 4 renal tubular acidosis. The etiologies are drugs like the ACE inhibitors or angiotensin receptor blockers. Then aldosterone antagonists like spironolactone. These are the one which can cause the type 4 renal tubular acidosis. Okay, yeah, the answer is B. In the sense type 4 is most common. Now one more clinical scenario you see here, that is a 45-year-old lady presented with features suggestive of mononeuritis multiplex. She gives a history of regular intake of medications for bronchial asthma preceded by allergic rhinitis. She also has the cutaneous purpura. The blood routine examination revealed the eosinophilia. The diagnosis to be considered in this clinical scenario is microscopic polyangiitis, endogenous bronchial asthma, Church-Strauss syndrome, Wegener's granulomatosis. Very good. So it is very much suggestive of the Church-Strauss syndrome. What exactly is this? It is a small vessel vasculitis. Right? It is the small vessel vasculitis. So in Church-Strauss syndrome, you will have peripheral eosinophilia and you will have the cutaneous purpura, that is cutaneous manifestations. Then mononeuritis multiplex is there, and there is also asthma and as well as the allergic rhinitis. All these will make the diagnosis of the Church-Strauss syndrome, right? Whereas you take in microscopic polyangiitis, the most common symptoms in microscopic polyangiitis is the involvement of the kidney, right? And along with that, the kidney inflammation, there could be skin lesions and as well as the nerve damage. But the involvement of, that is your skin purpura and all, they are like, sorry, the bronchial asthma and allergic rhinitis, they are all little rare in case of the microscopic polyangiitis. Whereas Wegener's, you have involvement of upper respiratory tract involvement, there will be lower respiratory tract involvement, and then there will be renal involvement. Okay, that is glomerulonephritis. That is what is the triad that you will see in case of Wegener's. And the type of glomerulonephritis in case of Wegener's will be Wegener's granulomatosis. That is what you will, sorry, crescentric glomerulonephritis, right? Crescentric glomerulonephritis is what you will see in case of the Wegener's granulomatosis. Okay, right. One last quick question and then we will wind up this session. Last question. A 68-year-old man who has had a recent syncopal episode in the hospitalized with congestive heart failure. Who had a recent syncopal episode is hospitalized with congestive heart failure. His blood pressure is 160 by 80 millimeters of mercury. Pulse rate is 80 beats per minute, and there is grade 3/4 harsh systolic murmur, and echocardiogram showed disproportionately thickened ventricular septum and systolic anterior motion of the mitral valve. Which of the following findings would most likely be present in this man? The options are radiation of the murmur to the neck, decrease of the murmur with hand grip, delayed carotid upstroke, reduced left ventricular ejection fraction. Yeah, so first of all, tell me, what is the diagnosis of this individual? What is the diagnosis of this patient? Yes, what is the diagnosis first of all? Yeah, so it is a case of idiopathic hypertrophic subaortic stenosis. Okay, basically either we call it as the HOCM, but the point is we cannot call HOCM. Okay, we can consider the hypertrophic obstructive cardiomyopathy, or we can consider it as idiopathic hypertrophic subaortic stenosis. What is the one important point to tell in the 2D echo? It is HOCM or idiopathic hypertrophic subaortic stenosis, that is the presence of SAM. Okay, presence of this SAM tells you it is the HOCM. Now this HOCM murmur, it is the ejection systolic murmur. Murmur will not radiate to the neck. The murmur of the HOCM will not radiate to the neck. But whereas the murmur of aortic stenosis, that will be radiating to the neck. Okay, Now, your delayed carotid upstroke will not be there in HOCM. In HOCM, you will have double carotid upstroke. And in case of HOCM, you don't have reduced left ventricular ejection fraction. You will have preserved, right? You will have preserved left ventricular ejection fraction in HOCM. Now, what will happen to the murmur with hand grip? There will be decrease in the murmur with hand grip. Why? Because with the hand grip, what will happen to the afterload on the heart? The afterload on the heart increases. When the afterload on the heart increases, the LV volume increases, because when the afterload on the heart is increasing, your left ventricle is unable to pump the blood into aorta, the LV volume increases. When LV volume increases in HOCM, the murmur decreases, right? The murmur decreases. So that is what is the concept of why the murmur decreases with the hand grip. So just please remember, with the hand grip, right? With the hand grip, the afterload on the heart increases, and because of that there will be increase in the LV volume. Why there is increase in the LV volume? Because LV is unable to pump the blood into aorta. That is the reason why the LV volume increases. And in all the conditions wherever the LV volume increases, the HOCM murmur decreases, right? The HOCM murmur decreases. Now, what are the other conditions where the HOCM murmur can decrease? All the conditions whichever will increase the LV volume, like supine position, okay, supine position, the LV volume can increase and thereby the murmur will decrease. Then next is in squatting position, next is passive leg rising, right? Passive leg rising, then sustained hand grip. And what are the drugs which can reduce the contractility and thereby increase LV volume? That is the beta blockers, then the calcium channel blockers. Okay, so these are the conditions where the murmur of the HOCM decreases. Then what is the condition where the HOCM murmur intensity increases? The murmur of HOCM, it increases, right? Very good, Sunjit. That is in Valsalva, right? And sudden standing, right? Sudden standing, patient on nitroglycerin, patient on diuretics. So these scenarios, the LV volume decreases, murmur increases in HOCM. Okay, so this is about the HOCM story, right? I hope everyone has understood this question, right? So these are some of the important PYQs which I wanted to do before the exam. So it was, yes, it was a little lengthy session of 2 to 2.5 hour session, and because once you are going near to the exam, right, I just don't want to discuss further PYQs like in the month of March. So that is the reason why I have taken a little lengthy session to cover the maximum number of questions. Okay, so I wish you all the best for your exam. Keep your belief and as well as hope high. Be with a positive attitude that definitely you can clear the exam, and don't try to read any new things in the last moments of your preparation. Just stick on to your notes as much as possible. Try to do as many number of revisions as possible that you can, but your hope and your spirit should be very high. Your attitude should be a positive attitude, and at this moment of time you should not leave your preparation. And these 4 days or 3 days whatever are remaining, try to be positive. Don't lose your hope at any moment of time. Okay, so with this I'll just wind up this session, and I wish you all the best for your exam, right? And once your exam is over, you can just text me on my WhatsApp the questions of the general medicine which will be helpful for me for doing the recall of the general medicine questions. And this is my WhatsApp number. Okay. So thank you very much. See you again in the subsequent sessions, which you don't require because you all will clear the NEET PG exam, where you will not be requiring my sessions further. Thank you very much.